Welcome to Med-Surg, and this is the orientation that every new nurse deserves but rarely gets. If you're a new nurse and no one has explained it to you, I made this series just for you. My name is Nurse Key, and I'll be your professor today. We are going to talk about oxygen. Now, oxygen is a medication, and like any other medication, it has indication, limits, and risk. So let's get into it. On Med-Surg, your job is not only to push oxygen endlessly. Your job is to recognize when oxygen is helping and when it's longer needed. Now, here's the rule. You can increase oxygen as your unit's policies are written. When your oxygen requirements keep rising, this is no longer a routine adjustment. This is a change in change of status in the patient. So when your patient goes from room air to nasal cannula, you start your nasal cannula as 2 liters. They maintain the oxygen saturation. Okay, cool. Report it and document it. But now if that person goes from 2 to needing 6 and still having distress, once you start to think of a high flow oxygen mask, you need to start considering escalating to a higher level care unit. When you put a high flow on, it goes from 10 to 15 liters of oxygen. That usually means that something underlying is happening with that patient and it needs to be escalated. So on a Med-Surg unit, you're commonly going to see room air. That means no oxygen, no supplemental oxygen devices attached to the patient or given. Nasal cannula, simple mask, and sometimes a non-rebreather mask depending on your unit. So when you are reviewing your patient and assessing, you need to know what oxygen device your patient is on, how much oxygen are they receiving, and what their baseline requirement is. Now, oxygen is not about chasing saturation numbers, it's about the trend. What were they on before? What are they on currently? And how quickly did that change happen? The patient who demands more oxygen to maintain the same saturation is deteriorating. Now, let's be clear about the limits. When a patient requires high-flow oxygen, a continuous BiPAP, advanced respiratory support, this is beyond the scope of a typical Med-Surg unit. You do not need to determine the treatment. You just need to recognize that the level of care has changed. So when oxygen escalation needs are no longer effective, you'll do 3 things. You'll reassess the patient, you'll notify the provider, and you'll activate rapid response. Now, you'll clearly communicate what the patient has started on, what they're on now, and how they're responding to it. When the oxygen requirements increase, this change has to be documented. You'll document your assessment, your intervention, who you notified, when you notified them, what was their response, and what is the patient's response to this intervention. Documentation is going to tell the story of your clinical judgment. As new nurses, they can often keep turning up the oxygen quietly, hoping that the patient will stabilize. But you have to remember that oxygen is a medication. There are certain conditions like COPD where you should not increase the oxygen you should just not increase the oxygen to certain limits. COPD patients generally do not receive more than 4 liters of oxygen because it can knock out their respiratory drive. So while oxygen can be a solution, it is not a solution for respiratory failure. It's actually a support. When the support stops working, escalation is the answer. This oxygen therapy framework is laid out, among other things, in the new nurse fast track. So you have to know the limits of oxygen and when escalation is required. If you want clarity on your shift, on your unit, and in your career, the link is in my bio. In the next video, we are going to talk about lung sounds, what normal sounds like, what abnormal sounds like, and what those sounds actually mean. Welcome to Med-Surg, and let's keep building. Welcome to Med-Surg, and this is the orientation that every new nurse deserves. If you're a new nurse and you feel like you have not had the knowledge and support and the training that you wanted, this series is made for you. My name is Nurse Key, and I've been a nurse for 6 years. I didn't have the best new nurse experience, and so I'm changing the status quo for new nurses. Today we're going to talk about lung sounds and what they sound like, what abnormal means, and when to act. You've already learned how to listen to lung sounds. You learned where to place the stethoscope. What matters now is knowing what those sounds mean and what to do when they change. Here's the rule. You listen to establish normal. When you hear abnormal lung sounds, these findings must be reported and documented. I'm going to walk you through the lung sounds and the way that nurses actually use them on Med-Surg. Normal sounds first, abnormal next. then what requires escalation. So normal lung sounds are clear and equal bilaterally. They may sound softer at the bases, but air movement should be present. Just like you hear when you can take in a breath and exhale, this is what it should sound like at the chest wall. It should be like a full volume and not diminish, right? This is your baseline. You need to know the normal, and then you need to know what is normal for your patient so you can recognize what change is later. When lung sounds are diminished or absent, this is like the volume being turned down, right? If clear and equal is full volume, diminished and absent is like the volume being turned down. This means that less air is moving throughout the lung spaces. This can indicate atelectasis, fluid, pneumonia, or airway obstruction. Diminished and absent breath sounds are not normal. They again need to be reported and documented. Next, we'll talk about crackles. Crackles are like fluid or inflammation over the lungs, or in the lungs too. You may hear this with heart failure, pneumonia, or fluid overload. If the crackles are new, worsening, or spreading, go ahead and report this and document that you found this. These are some changes in respiratory status that would need escalation. Now, if your patient's CHF, pneumonia, it's already been diagnosed, sometimes you can expect that, right? So if you have a pneumonia patient or CHF, you listen to the heart sounds, you hear like crackles, you hear fluid overload, less air moving through, this can be expected. And for example, if you have a CHF patient, and then you give Lasix or some form of diuretics, you may expect that crackle sounds to actually lessen and then the lungs to become clear or diminish. This does happen. So that's why lung sounds is not just a one-time assessment. You actually need to go back and reassess due to intervention, just to see how the patient is progressing. We'll also talk about wheezing. Wheezing is often like the most easiest to pinpoint because most of us are familiar with what wheezing sounds like, and this determines or indicates a narrow airway. This can be in asthma, COPD patients, or bronchospasms. If the wheezing is new or worsening, it may be a stricture. It may be like now the respiratory has tightened, and it could be an airway problem. So that would be definitely a quick intervention will be needed. The biggest mistake that new nurses will make is when they hear abnormal lung sound, just because they may not be able to dictate what sound it's. The biggest mistake that new nurses make is because they cannot name the lung sounds that they hear and they know that it's abnormal, they do not act on it. The biggest thing is to know the normal. Anything abnormal, you're going to document it and report it. Assessment without communication is incomplete care. If lung sounds change, someone needs to know. So lung sounds are just one piece of the puzzle. You're always going to pair them with the respiratory rate, work of breathing, oxygen requirements, and the symptoms of the patient. Abnormal sounds plus increased oxygen demand is not something you watch quietly. So when does it need escalation, right? Because you're going to report and you're going to document it, but some things are actually critical and time sensitive. If your lung sounds start to worsen where they're clear and now they're absent, you're going to escalate. If your oxygen, if that person was on room air and now they're needing 6 liters of oxygen just to maintain a normal oxygen saturation, you're going to escalate when the oxygen needs increase. If the work of breathing increases where they were laying there non-labored, peaceful, and now all of a sudden they're in tripod position, they're using accessory muscles and nasal flaring, you're going to escalate. These situations, you're going to notify the provider as quick as possible and activate rapid response if that falls into the parameters of your facility. You do not need to diagnose the problem and articulate, oh, this is exactly what's happening. You as a nurse just need to know the abnormal and that this is critical and this is time sensitive and you need to act appropriately. Altogether, this is why hearing lung sounds actually matter. When you know what lung sounds are like at its normal, and then the abnormal will stand out, then you will know when to escalate when the abnormal appears. All right, so this is the exact lung sound framework that I lay out in the New Nurse Fast Track. Being a new nurse is already difficult, and it's made more difficult because sometimes we don't have the proper education, the support, or resources to help us become the nurse of our dreams. I created the New Nurse Fast Track because I didn't want any other nurse to have a bad experience in their first year. New nurses are leaving the bedside at quicker rates than ever before, and I definitely believe it's due to lack of education, community, and support given by the nursing community. And so I think it stops here. The link is in the bio. Go ahead and like and follow and share this with all the other new nurses that you know, and I'll see you for the next video. Welcome to Med-Surg, and this is the orientation that every new nurse deserves. If you're a new nurse and no one has explained this to you yet, this is the series for you. Now, I'm Nurse Key. I've been a nurse for the past 6 years, starting off as an LPN, and now I'm a registered nurse, working her way through NP school. So today we're going to talk about cardiac assessment on Med-Surg, the vitals, symptoms, and trends that actually matter. Now, cardiac assessment is not just about memorizing heart sounds. It's about recognizing instability early. When it saves a patient on Med-Surg, this is not diagnosing cardiac disease. It's about recognizing when something is changing and escalating it before it becomes an emergency. So here's the rule. You're going to assess the normal. Understanding the normal helps you to understand the abnormal. When you find an abnormal cardiac assessment, those findings have to be documented and reported. So you're going to be focused on 4 things. Number 1 is blood pressure trends. Number 2 is the heart rate. Number 3 is the symptoms. And number 4 is perfusion. So blood pressure is not a single number. You're going to say, is this normal for a patient? Is this trending up or trending down? Now, a sudden drop or persistent hypotension or uncontrolled hypertension is not something to watch quietly. The blood pressure changes from the baseline. This is abnormal and it requires follow-up, reporting, and documentation. Number 2, the heart rate. What should make you stop? With the heart rate, you're watching for changes and not perfection. Tachycardic, bradycardic, or new irregularity should always make you pause. If the heart rate changes and the patient is symptomatic, this is no longer routine care. You have to start to escalate it. There are symptoms that matter more than the number. These are often the most earliest warning signs. This is chest pain, shortness of breath, dizziness, diaphoretic, new anxiety or restlessness. These are now underlying subtle symptoms at times that are going to indicate bigger changes that you're going to have to escalate pretty quick. If the patient is saying that something feels wrong, please listen to them. The patients are their best source of assessment, best source of truth, and we need to start listening to them. The symptoms plus abnormal vitals should never be ignored. Now, perfusion. This is going to tell you how well the heart is circulating to support the body. You are going to assess your skin color, or their skin color, temperature, cap refill, mental status, and urinary output. These are all indications of perfusion. Again, if these are starting to change, this is showing you an underlying problem. Poor perfusion is a sign that the patient may be decompensating, even if the numbers don't support it and they don't look dramatic just yet. Now, if your patient is on telemetry, which is like continuous heart monitoring, EKG, you're not expected to diagnose the rhythms, but you are expected to recognize the rate changes, new irregularities, new dysrhythmias, or alarms that don't match the baseline. Typically, when patients go into cardiac arrest or even BFib, that's not actually it doesn't just happen like that all of a sudden, generally. Watching the monitors for years and just sitting there, and I'll watch other patients or while I'm charting, I've noticed that generally there's a pause and then it returns back to normal before a patient's heart turns into a critical life-threatening rhythm. It's usually a pause, it's a few second pause. It returns back to their baseline and then it goes into an unstable rhythm. So knowing the patterns in nursing generally can save you. If you get ahead of the small changes before they add up to big life-threatening status changes, that can save you. If a telemetry changes, if the EKG rhythm changes and the patient becomes unstable, this is going to require provider notification and possible rapid response to be called. Now, sometimes new nurses focus too much on individual numbers, and it's no fault of their own. We are so focused on sometimes just the vitals and just individual assessment factors that we don't know how to tie in the full picture. Generally, they may wait because the blood pressure isn't that low or the heart rate isn't that high yet, not knowing that deterioration is not about the thresholds, it's about the trend. Are we trending upwards? Are we trending downwards? By the time the number looks bad, you are already behind. The number is usually the last thing to change. So, you need to learn to escalate when the vitals trend away from the baseline, when symptoms appear or tend to worsen. The perfusion decreases, right? The temperature gets cold, cap refill increases. They have lost a pulse, or their lung sounds start to diminish or become absent, or the patient starts to look unstable, restless, agitated, lethargic, non-responsive, sluggish. Again, you don't need to diagnose the problem. You don't even need to know the full situation, but you need to be able to articulate the symptoms that are telling you something else is going on. You need to recognize that the patient is no longer stable on the level of care that your unit provides. Now, this exact cardiac assessment framework is laid out in the New Nurse Fast Track. This is something I created for new nurses in their first year to understand how to support their patients, their skills, and critical thinking. You need to understand what to watch, what matters, and when escalation is required. If this is something that you need and you need clarity on your shift, go ahead to the link in my bio, and the least you could do is go ahead and like this video, follow my account, and share with other new nurses like you that may need this content. All right, I'll see you in the next video. Welcome to Med-Surg. This is the orientation that every new nurse deserves but rarely gets. Hey, my name is Nurse Key, and I've been a nurse for the past 6 years. Starting as an LPN, I'm now a registered nurse, working my way through NP school. So if you're a new nurse and no one has explained this to you yet, I made this series just for you. So let's talk about how nurses should interact with the doctors. Now, in nursing school, they talk about SBAR, but let's go a little beyond that. So oftentimes, a lot of nurses are intimidated, or they struggle to talk to doctors, or they don't really know what to tell them. Let's talk about even the rules of working with doctors, right? Doctors are not your bosses. They are your co-workers with a different role. Now, of course, in the hierarchy of nursing, doctors, you do work under their supervision. They give us the medical orders and we apply the treatments. We got that. But we actually collaborate alongside of each other, and we have to work together. So the problem isn't confidence. It's usually your communication style. Do not talk at the providers. Actually talk to them or with them. The providers, they don't necessarily need your entire background of the situation, every moving part, or the play-by-play of the shift of how you got to this conclusion and why you're calling them. They need the problem, the risk, and present the solution that you even called them for. So instead of dumping information into their lap, lead with what changed, why it matters, and what you need now. So when you call unsure, it sounds unsure. When you call with a plan, it sounds collaborative. So for example, you say, hey, I'm concerned about this patient's increased work of breathing. When I started my shift, they were on room air, unlabored, no shortness of breath, no signs of distress. 2 hours has passed. I'm back in their room doing my rounds. Now they have labored breathing. They're posturing where they're in tripod position. And it seems like they're in more shortness of breath. I went ahead and put them on 2 liters nasal cannula. They're setting at 95 when they were setting at 100. What would you like me to do? Would you like me to increase it from 2 to 6? Or do you want to order a breathing treatment? Give them some options, try to anticipate the solutions. But if at the very least, go ahead and cut to the chase. Hey, we're having a respiratory issue, and you can say that at the beginning of the call. My patient has desatted. I applied oxygen. They're now satting this. What do you want me to do next? This tells them that you're thinking, not just reporting. So when you're speaking to the doctor, you're not asking for permission. You're just advocating patient safety. You are explaining what is going on with the patient from your perspective, verified by the numbers, vitals, the patient presentation, and now you're asking for input from the physician to collaborate on what's best for the patient. So when nurses communicate like colleagues, physicians or providers can respond like partners.